The next talk will be given by Dr. Chris Follansbee, who's an assistant professor of pediatrics and an excellent clinical electrophysiologist. We're lucky to have him back. And he'll be telling us today about electrophysiology considerations in Fontan-Kreutzer management.
Good morning. Thank you for the opportunity to be here to talk with everybody. As we've heard about from a variety of perspectives, arrhythmias have really been a troublesome component for the Fontan population since their inception. The atriopulmonary Fontan in particular had notoriously high rates of tachycardia concerns, with some data sets showing incidence of atrial arrhythmias exceeding 65% in this population. This is from the Australia-New Zealand registry, which shows a more typical estimation of the mid-40% for the arrhythmia population. With each surgical advancement that we've seen a correlating decrease in the burden of arrhythmias going to the lateral tunnel and ultimately the extracardiac Fontan. However, this still remains a significant source of morbidity and mortality within the Fontan population. And this is not just from a tachycardia standpoint. We also see the same data emerge from a bradycardia standpoint, albeit to a lesser incidence than the tachycardias. As we've seen before, the predominant form of arrhythmia that we deal with is atrial tachycardia, which can result in loss of AV synchrony and increased end diastolic pressures, which is not well appreciated in a passive flow pulmonary system. This is associated with a significant thromboembolic risk, with up to 19% incidence of atrial thrombus in the sustained arrhythmia population, as well as the onset of heart failure. It has historically been an ominous finding, with 52% of patients with late-stage Fontan mortality being known to have persistent atrial arrhythmias. And in the AP Fontan population, it was particularly ominous, being associated with a 6-fold increase for the risk of death or transplant, which translated to a 6-year mortality rate exceeding 40%. Intraatrial reentrant tachycardia has by far and away been our primary adversary in this realm, accounting for up to 93% of the tachycardia mechanisms in some data sets. It's followed distantly by non-automatic focal atrial reentrant tachycardia, and then a small smattering of more typical forms of SVT. Intraatrial reentrant tachycardia is caused by the formation of scar lines, either surgical or from progressive fibrosis due to remodeling in atrial myocardial tissue. This results in electrical blockade, allowing the formation of slow conducting channels supporting reentrant circuits. The rule of thumb when it comes to IART is multiplicity of circuits, with AP Fontans being found to have an average of greater than 2 circuits per ablation attempt. Unfortunately, as we've heard, medication has had limited success and often complicates underlying sinus node dysfunction or ventricular dysfunction, limiting the use of beta blockers in this population. And unfortunately, we've also seen increased susceptibility to side effects with medications such as amiodarone due to impaired hepatic processing and increased iodine levels, leading to a high incidence of thyroid toxicosis with long-term amiodarone in the Fontan population. The good news is, though, that we've seen excellent advancements in the technology around 3D mapping systems, the advent of multipolar catheters that allow for rapid, high-density mapping, and cooling tip catheters that improve tissue penetration, allowing for shorter procedure times with improved acute success rates. Currently, we enjoy acute success rates for IART ablation that reach up to 90%. However, this does need to be taken within the lens of that Fontan patients have the highest recurrence rate of arrhythmias within the congenital heart disease population, with studies showing 40 to 50% of patients will develop new arrhythmias within 1 to 3 years post-ablation. In that setting, we really should potentially think about catheter ablation more as a palliative procedure with the goal of decreasing hospitalization time, heart failure symptoms, and medication needs. Studies have shown that the atrial size as well as the low voltage area size are good predictors of recurrence. Our population is also changing with an ever-growing older population of Fontans, as we've heard about in our prior talks. And now we have significant numbers in the third, fourth, and even fifth decade of life. And as we see this growing population, we're seeing a change in the composition of arrhythmias. This was an interesting study that was presented, or that was published in 2017, looking at congenital or ACHD across the board, though also including single ventricle population. And what we saw is that we are seeing a slow transition of the paroxysmal and sustained IART, or the typical atrial tachycardias, being slowly replaced by the emergence of paroxysmal and sustained atrial fibrillation in our older patient populations. When they looked at potential etiologies that may be contributing to this transition, we see a change from our typical risk factors that we've known about, which included the increased complexity of their underlying congenital heart disease, bradyarrhythmias, as well as the presence of pacemakers, as well as the number of cardiac surgeries or atrial scar lines. And we've seen a transition to our adult patients, well, behaving more like adults. They now have older age, they have higher BMIs, they have hypertension, dyslipidemia, they smoke cigarettes, and they've developed coronary artery disease. And so in many ways, they are simply behaving more like typical adults. In response to this, though, the electrophysiologists, we've had to expand our thought process in our ways that we're going to manage our patients and potential therapeutic options, which has really moved us more towards the introduction of pulmonary venous isolation as a potential procedure to help deal with the burden of arrhythmias. In the setting of this, our approach has adapted somewhat. For our patients that have onset of sustained arrhythmia episodes, we have moved towards initially beginning with our comprehensive clinical evaluation to get a full understanding of the physiologic health of the patient, as well as any hemodynamic concerns that may be contributing to the increasing arrhythmia burden. We obtain cross-sectional imaging, as Dr. Al-Sayed just showed, that can help us guide procedural decision-making, as well as vessel Doppler ultrasounds, since access is never a guarantee in this patient population. We perform our procedures with a multidisciplinary team, including interventional cardiology, pediatric, as well as our adult electrophysiology colleagues when we plan for pulmonary vein isolation. We always perform a comprehensive hemodynamic assessment, which Dr. Goldstein will share us some more information about that in the talk to follow, I suspect. And then where appropriate, in addition to addressing the IART circuits, we perform a pulmonary vein isolation with our empiric short-term outcomes being very positive. A note about following ablation in our care. It is very important for aggressive anticoagulation following pulmonary vein isolation and aggressive IART ablation in this population, given the very high risk of thromboembolic events. We have transitioned over to 2 to 3 month coverage with a DOAC, as well as 2 to 3 months of additional antiarrhythmic coverage, as this patient population has a high incidence of post-ablation irritational automatic tachycardias. Moving along, the next big component in the tachycardia picture is the ventricular tachycardias, which fortunately have had a much lower incidence than the atrial arrhythmias in this population. However, we still have many questions that surround the significance and really optimal management strategies of ventricular tachycardia in this population. But fortunately, as the universe tends to supply, 2 days ago, we had a new publication looking at the burden of ventricular arrhythmias in the Fontan population. This is in the most recent issue of Circulation, Arrhythmia, and EP, and is published by the Stanford group. This is a single-center retrospective study involving 431 Fontan patients from 2002 to 2019. In this, they had an overall ventricular arrhythmia incidence of 11%, which was 90% non-sustained VT, and very similar to what we typically see on our Holter monitors, where you catch triplets, quadruplets, and short, relatively slow monomorphic runs. They had 10% sustained runs and a relatively low incidence of malignant arrhythmias, which they defined as hemodynamically unstable at 2%. There were several key findings that were supported by this study and are fairly interesting. As most of us have long suspected, the risk of ventricular arrhythmias increases from the time of the Fontan surgery moving forward. And they confirmed this with a risk of 2.4% at 10 years and increasing to a 19% risk at 20 years post-Fontan. The malignant ventricular arrhythmia cohort, interestingly enough, had a lower age with a median age of 14.3 years compared to the median time to overall ventricular arrhythmia development at 15.9 years post-procedure and a median age of 21.3 years. This was also associated with worse baseline systolic function and AV valve regurgitation, which we've long known have been risk factors in this population. An interesting analysis is that they subdivided their cohort into a Stanford-only group, meaning Fontans that have only been cared for in Stanford, and their entire cohort, which included a large number of referrals for post-Fontan advanced care in an effort to control for selection bias in their referral population. When they ran their analysis, or Cox multivariable analysis, in both of these groups, only 2 factors bore out as statistically significant in both groups. The first was having a stage 1 repair with an RV to PA conduit, which had previously been demonstrated by Hall et al. To be a risk for the development of ventricular arrhythmias, and makes sense when we compare it to other congenital heart disease cohorts that are associated with ventriculotomy scars, particularly the tetralogy of Fallot community. Additionally, we saw that an increased age at the time of Fontan was associated with the risk of development of ventricular arrhythmias, which is consistent with data that we've seen in the development of atrial arrhythmias and sinus node dysfunction as well. Finally, a curious finding when they looked at the systolic function at the time of the diagnosis of ventricular arrhythmias, 65% of the patients had normal or only mild systolic dysfunction at the time of their arrhythmia diagnosis. But more concerning, in their data set, there was no difference in the long-term outcomes between the preserved systolic function cohort and the moderate to severely depressed cohort. While this could be a simple matter of sample size, not adequately able to discern the difference here, it is certainly concerning for those patients where we frequently see relatively short, non-sustained monomorphic runs on our Holter monitors. And probably the most impressive takeaway point from this study was the very strong association they had with the increased risk of transplant or death, with a hazard ratio of 9.2 and 48% transplant-free or 48% transplant-free survival at 5 years post the diagnosis of ventricular arrhythmias in this population. So it still leaves the question for us as clinicians taking care of this cohort of what we do when we finally diagnose ventricular arrhythmias. And for a large part, I don't think that we still clearly know what the optimal approach is. I think the data clearly supports that we need to be routinely surveilling for the onset of these, and when they are detected, comprehensive evaluation aimed at optimizing hemodynamic factors, as well as early consideration of potentially antiarrhythmic and heart failure therapies, may be even directed at our patients that have more preserved systolic function than we previously had thought. ICD implantation remains a difficult subject given the technical difficulties with placing an epicardial ICD lead, and unfortunately, Fontan patients have a low success rate for screening for subcutaneous ICD implantation as a less invasive option. Further compounding this, actually, in Stanford's experience, they had 7 patients with ICDs implanted, and none had an appropriate or an inappropriate discharge at a mean follow-up of 1.8 years. Which really, I think, in the end supports that ICD therapy may still be best targeted at the patients with a malignant ventricular arrhythmia presentation, particularly in the setting of diminished systolic function. The other question will ultimately be the onset of ventricular arrhythmias versus the optimal timing for consideration and evaluation of transplant therapy. Quickly, I do just want to talk about bradycardia and pacing. As my previous slide showed, there is significant sinus node dysfunction in the post-op period for the Fontan population. It's associated with decreased autonomic control of the heart, manifesting as decreased heart rate variability, depressed baroreflex sensitivity, as well as chronotropic incompetence, seen in up to 62% of the Fontan population. The PD Heart Network registry shows an incidence of 13% of pacemaker implantation within the Fontan population, which in that specific registry is predominantly extracardiac. It's associated with lower quality of life, lower ejection fractions, increased risk of death, transplant, and Fontan failure, as well as ventricular pacing itself. It's associated with a 13-fold increase in the risk of death or transplant. This was a study from 2022, also out of the Stanford group, which was aimed specifically at trying to tease out factors with ventricular pacing that may modify the course for our single ventricle patients. Looking at kind of the classic path, they found a lot of the things that we suspected were true, though they were able to more definitively show. And as we expected, there was a lower survival from moderate or worse ventricular dysfunction in the setting of ventricular pacing. There was a lower freedom from Fontan failure, and there was a lower freedom from transplant in patients that were being ventricularly paced. They were able to identify 2 protective factors for ventricular pacing, and that included a lower burden of ventricular pacing, which is denoted by the blue line on the left side, which would be defined as less than 85% ventricular pacing versus greater than 85% in the red line, as well as apical positioning of the ventricular lead, which is denoted in the black line versus the green line, which is non-apical lead positioning. Finally, they unfortunately did not have sufficient numbers to look at other mitigating factors, particularly multi-site pacing, which is the single ventricular form of CRT. This has really been a challenging enigma for the electrophysiology community, really going back even to the earliest studies, which has been plagued by low numbers and really mixed outcomes as far as clinical improvement. Even more recent studies, from which this is one from 2018, detailing the Boston experience with multi-site pacing. And even in this case, they were unable to show significant difference in outcomes at 5 years for multi-site pacing, which, as far as this has led to shaping our approach, I think as an institution, we really aim to try to achieve an apical lead position where feasible. As our approach, and we particularly try to aim to minimize our ventricular pacing needs, either using adaptive pacing programming modes or by prolonging AV delays, trying to encourage intrinsic ventricular activation as much as possible. Regular surveillance is very important in this group for the early detection of dysfunction. And I think in the future, it will become a risk-benefit talk ultimately for multi-site versus transplant evaluation. But I think unfortunately right now, we haven't quite teased out exactly who the optimal candidate is for multi-site pacing or potentially some technical approaches that may help to ultimately improve our efficacy with multi-site pacing. Thank you.